Welcome to Direct Supply's Continuing Education webinar series. Direct Supply offers monthly webinars on a variety of topics throughout the year. The topic for today is Understanding the Geriatric Population, Risks Associated with Prolonged Sitting, and Goals of an LTC Therapist. My name is Robin Malik, and I'll be facilitating today's meeting. This webinar includes one nursing contact hour, one physical therapy contact hour, one occupational therapy contact hour, and one complimentary administrator CEU approved by the NAB. If you have questions during today's presentation, simply use the chat feature to submit your question. Send your questions to me, Robin, the host. We will answer as many questions as possible at the end of the webinar. Please note the information contained in this presentation is intended to provide general information, but not legal advice, about certain regulations and initiatives. This is not intended as legal or other advice, and each situation may vary depending on the particular facts and circumstances. You should not act upon this information without first consulting with qualified legal counsel. Today we are joined by Ana Endsio. Ana is an occupational therapist with a Master's of Occupational Therapy degree from Nova Southwestern University and a Bachelor of Nutrition and Dietetics degree from the University of Delaware. Ana has worked as an occupational therapist for over 15 years, mainly with the geriatric population in a variety of treatment settings, including acute care, subacute care, outpatient, acute rehab, long-term care, and as a lymphedema certified therapist. Over the last 9 years, she has been dedicated to the betterment and treatment of the elderly in the LTC centers. Her time was focused on seating and positioning and contracture management of the nursing home residents. Through this experience, her hope is to guide other therapists, rehab directors, nurses, and administrators through blogs, webinars, and live courses to be able to do the same. And now, please welcome Ana.
Thank you, Robin. As Robin mentioned, my name is Ana Endsio, and I am an occupational therapist by trade, and I am also the Clinical Education Manager for the Long-Term Care Division of Comfort Company. And I am pleased to be here partnering with Direct Supply to offer you one of our many courses in seating and positioning. We have developed this course for the generalist therapist, just like you and I, that this is not all we do day in and day out, but this is becoming a very important part of our day, something that we must have better knowledge in. And so I hope you enjoy this first course, and I look forward to seeing you in some of the upcoming courses that Direct Supply and I will be offering to you in the future. So today's course is titled Understanding the Geriatric Population, Risks Associated with Prolonged Sitting, and Goals of the Long-Term Care Therapist. Now, with that being said, I will tell you that this course really does apply to multiple settings, for the home health therapist, for the acute hospital therapist. So if you're not a long-term care therapist, please understand that this information is really good across settings. So the objectives for today's course is that I would like for you to be able to name 3 health risks associated with prolonged sitting in one of the abnormal postures. Number 2, I would like for you to name insights gained during the evaluation when asking the key question, what activities must your resident be able to perform? And lastly, I want you to name 2 insights gained during the evaluation when asking the key question, what are the pelvis, the trunk, and the head doing when the resident is sitting unsupported? So a good place to start is why. Why do we slide into abnormal postures? And when we're dealing with the elderly population, the answers are quite easy. We're dealing with a population that is sitting or lying in the same position for hours on end. And so we know that our muscles automatically are going to get tighter and shortened. And when we consider that in terms of wheelchair positioning, what is the muscle that is most affected? What is the muscle that is shortening the most? And that is your hamstring muscle. And so when you start to consider that, you have someone sitting in a chair and you have their hamstring muscle and it starts to shorten and shorten and become tighter and tighter, it's going to pull on the bony prominences at the joints that they are attached to. And where is our hamstring attached? It's attached to our pelvis and it's attached at our knee. So it'll start to pull on the pelvis and bring that pelvis into an abnormal posture of most likely a posterior pelvic tilt. And it's also going to pull at the knee and bring that knee into more flexion. And as those muscles get shorter and tighter and they stay in those positions for long periods of time, we start to see the development of contractures, especially at the hips and the knees and the ankles, that really start to pull on our bodies even further into all of these abnormal postures. As well, and you can see that quite clearly on the picture I have up there of the young therapist that's very linear, walking with her elderly resident that is very curved. As we get older, with every decade of life, we start to go into more of a curved posture, especially at our thoracic and lumbar spine. And so that makes it very difficult for someone to sit upright at that optimal posture, and they start to slide down, or they start to lean over, or they start to slump forward. As well, we're dealing with residents that through a lifetime of stress and strain have tons of pain at their joints, at their muscles, through the car accidents they've been in, the jobs that they've held as factory workers or farmers, through the hobbies that they've had. Maybe they were avid skiers. Whatever the case may be, we're dealing with people that slide into abnormal postures to alleviate pain, as well as we're dealing with people with limited mobility. So as they start to slide into these postures, they do not have the strength or the endurance to fight against gravity, fight against fatigue from sitting in a chair for long periods of time, to bring themselves back up to that optimal midline. And as we deal with all of these issues, these changes really do make our residents more prone to prolonged sitting in one of those abnormal postures. So what are the abnormal postures typically seen with prolonged sitting? And we've all learned these in school, and I'm going to go through each one and just kind of recap what they are. What are you looking at? And my goal with this is that you can walk up and down your hospital hallways, or walk through your nursing home hallway, or walk into someone's home, be able to document what you're seeing, know what the health risks associated with sitting in that posture for prolonged periods of time are, and then pick them up off of those quarterly screens, off of those annual screens, or that new admit screen, and really start to help them to sit in a proper wheelchair position. So the first abnormal posture that we're going to talk about, I place first on purpose. And the reason being is because it's the most commonly seen abnormal posture. And that is our beloved posterior pelvic tilt, that sacral sitting. And this is kind of one of those issues of what came first, the chicken or the egg. Our spine and our pelvis, we know, are integrally connected, and one is always going to affect the other. So this may be, you may see this posterior pelvic tilt because someone had a tendency to always be with rounded shoulders, and they have a very kyphotic spine that pulls them into more of a posterior pelvic tilt. Or maybe it's the posterior pelvic tilt that really pulls someone into that kyphotic posture. But either way, we need to know what we're looking at. We need to know how to document it and how to start to fix it. So when we see this and we get that person on the mat table and we start to palpate, we want to know what is going on at the pelvis. And so you always want to palpate your ASIS and your PSIS, and you will see that with the posterior pelvic tilt, that ASIS is higher than the PSIS. So you're producing that posterior pelvic tilt. You're seeing that sacral sitting posture. What's going on at the spine? And I honestly believe that this is the easiest way when you're walking past someone to recognize that they're sitting with a posterior pelvic tilt. And you can see that very well in the picture of the blue gentleman. And I call all of those images my blue man group. But you can see that at the spine, you'll see a C curvature. That's that rounded look that we see so many of our residents having. They have that C shape of that thoracic spine area. And then with any type of abnormal posture, you may or may not see the head being affected. But when you do see the head affected with posterior pelvic tilt, what is going on? You oftentimes see that resident that is looking down at their lap or at the floor constantly with that forward flexion of the neck. Okay, the second abnormal posture is not as commonly seen. It is called anterior pelvic tilt. But when we do see that in our nursing home setting especially, you oftentimes see this with a very obese, heavy patient. And so what is going on at the pelvis is the exact opposite as the posterior pelvic tilt. And you will notice that your PSIS is now higher than your ASIS. And the reason why is if you can picture someone in a wheelchair and they're very heavy, they are obese, especially in the pelvis area, all of that excess tissue pushes their pelvis forward into an anterior pelvic tilt. So what is going on at the spine? And you will see an excessive lordosis, especially at the lumbar spine. And if you look at the picture with the girl who is not obese in any way, shape, or form, but she is doing a great job of putting her hands at her lumbar spine for us to really show us that excessive lumbar lordosis that we get with an anterior pelvic tilt. And that, in layman's term, is usually called a sway back. So she's really showing us how sway back we become when we deal with an anterior pelvic tilt. So what is the head doing with someone with an anterior pelvic tilt? This, you will often see someone, as they go into an anterior pelvic tilt and they get that excessive sway back, you'll see a hyperextension of the spine, and it kind of goes over the back of the wheelchair. And then you start to see also a hyperextension of the neck, and you start to see someone with an upward eye gaze that they're constantly staring at the ceiling. So moving on to the third one is pelvic rotation. And this is probably one of the postural abnormalities that is least understood. And I didn't understand why until I started trying to teach it, and I started working with our graphic designers to try to build a database that actually shows one. So if you were to Google pelvic rotation right now, 9 times out of 10, you would actually see an image for an obliquity pop up. And I think it's for that reason, because it is a very difficult image to show. And probably the best way to show it is looking from top down, the way we did with our Blue Man group, drawing up at the top, so that you can see what the actual pelvis is doing. So when you palpate the pelvis and you have your fingers on the ASISs again, you will notice that one ASIS is more forwardly rotated than the other. It is not an obliquity, which one side is higher than the other. It's that one side is more forward. And you oftentimes see this with someone that is placed in a wheelchair that is too narrow. When they are in a wheelchair that is too narrow, they can't fit. So they have to actually turn their chair to try to fit in the wheelchair, rotating with one side more forward than the other side. I don't know if someone's not on mute, but I keep hearing a lot of background noise. I don't know if we can mute the phones, but hopefully you guys can still hear me okay. What is going on at the spine is that the thoracic spine also rotates in the same direction. So if you're looking at the picture of the gentleman below in his wheelchair, you can see that he has got his right side of his hip is more forwardly rotated, and you can see that his shoulder is following. He has now rotated with his spine as well, and his right shoulder is jutting out at us. And that is what you will oftentimes see at the spine. The head, this gentleman's head is not affected, but if it were to be affected, oftentimes you will see that lateral flexion where it seems like the ear is listening to what the shoulder has to say. And oftentimes it's even accompanied with a rotation and a forward flexion. And if you actually do that motion with me, it's very uncomfortable. You feel a lot of stress and strain on the musculature of the neck, and it's very uncomfortable for the resident. The next postural abnormality is pelvic obliquity. And as I said, this is a better known postural abnormality. It's very commonly seen one as well, because a lot of times we're placing our residents in wheelchairs that are too wide. And so oftentimes they have to lean to one side to try to make contact with the armrest to feel stable, and you promote that obliquity at the hips where one side is higher than the other. And the way I normally describe it is that I think of it when it's winter time and we have those big heavy winter jackets and we sit down in a chair, and then we want to take our jacket off, and we can't take it off completely because we're sitting on it. So we kind of lean over and pull the jacket out from underneath of us. We've just created an obliquity. One side of our pelvis is jutting into the cushion while the other one is barely making any contact with the seat surface. So what is going on with the pelvis? One ASIS is higher than the other, causing that hip hike. At the spine, as you can see in our Blue Man Group picture, you will see that they lean to one side, but the spine wants to try to get back to midline due to our natural righting reflexes. So you start to see this curvature, this S scoliosis curvature of the spine. The head is very similar to the rotation. You start to see more of a lateral flexion, which you can see very well on the gentleman below. You can see a lateral flexion, oftentimes with the rotation and the forward flexion. Okay, the last abnormality that we're going to talk about, that I want to make sure you understand what it looks like and what's going on at the pelvis and the spine and so forth, is not actually describing what is going on at the pelvis. It's actually describing what is going on at the lower extremities. So what is going on at the pelvis? This usually presents with a rotation or an obliquity. You can see a windswept deformity with a posterior pelvic tilt, but it's usually seen with a rotation or obliquity. So what are the lower extremities doing? And so if you have someone sitting in their lower extremities in alignment, it is almost as if a big gust of wind has come in and taken your legs over to one side of the chair together. So one of the legs will start to internally rotate an AB duct towards midline, and the other lower extremity will externally rotate an AB duct away. So again, as the name describes, it's like a big gush of wind has come in and taken those legs off to one side of the chair together. The spine will usually follow whatever the underlying cause of the pelvis is. So if you're dealing with a pelvic rotation, you'll usually see the spine is rotated. If you see an obliquity, you'll usually see someone with a scoliosis. And then the head is usually following that same pattern of the lateral flexion, forward, a little bit of rotation with forward flexion. So one thing I want you to understand is that abnormal postures in and of themselves are not bad things. You and I go in and out of abnormal postures constantly to relieve pain, to be more comfortable, to relieve pressure, out of boredom. You've probably gone in and out of an abnormal posture 6 times since I started speaking. However, when we allow our residents to sit in abnormal postures for prolonged periods of time is when we really start to see multiple health complications. We start putting our resident at risk for things that we want so desperately to avoid. So what I'm going to do is I'm going to go through these health risks and explain why. Why do they happen when we allow our residents to sit in these postures? So the first one is decreased respiration. And if you can see in that picture of our little lady down in her wheelchair, she is sitting, if I could hear you, I would ask you right now what posture she's sitting in. And I'm sure, as I said, because of the dead giveaway of that C curvature of the spine, you would tell me she is sitting with the posterior pelvic tilt, the thoracic kyphosis of the spine, and the forward flexion of the neck. Dead giveaway. And this is probably what we see the most in our setting. However, I want you to really notice that because she's sitting like this, she's constantly compressing her chest and her abdominal cavity. And we are dealing with residents that already have very compromised respiratory systems. So when we allow them to sit like this and we compress that abdominal cavity and that chest cavity even further, we don't allow their diaphragm to contract properly. And so less air can fill the lungs. It makes it more difficult for them to take a deep, adequate breath to get oxygen flowing through the body. Less oxygen is delivered, and so our bodies will naturally compensate. Our bodies try to fix themselves constantly. So you'll compensate by not being able to take that deep, adequate breath. You'll start to breathe faster and shorter, and it makes you even more tired. It takes so much energy expenditure to breathe that way. And you start to see the muscles fatigue and the person slumping down into that posture even more. So this is something very cyclic. We just keep building them up for failure by allowing them to sit in this type of posture. And we all know that when the lungs cannot be inflated adequately, the fluid just pools in the lungs. And then we are really setting our residents up for a higher risk of pneumonia. And I know that your nursing staff, that is one thing that's a bad little ding against us in the nursing home setting is how many bouts of pneumonia do we deal with. It can really bring someone down. It can really affect their quality of life, how many hospitalizations they have, the independence that they're showing with their ADLs. And so how much would your nursing staff love you if you could position these residents in a way that bring them up, that open that chest cavity to let the air flow through those lungs, get the oxygen moving, and decrease the risk of pneumonias in your center. Okay, so the next one is digestion. And just as I mentioned that you have constriction of the chest and the abdomen, the digestive system is being constricted as well. And so food will not be able to travel through the GI tract correctly, and the food will start to slow down and even get stuck. And it's often very comparable to someone who's pregnant, and you just have the movement of the food is slower. You start having issues such as reflux. You start having issues such as gastritis, constipation, impacted bowels. And I can tell you from personal experience with this resident right here, she perseverated on this so much, it engulfed her. And if you can see that sliver of brown on the door, that is her bathroom door. And she was perseverated so much on her bowel movements or lack of that she did not even leave her room any longer. She's parked herself right next to that door, and she truly would only, as the minute she felt something happening, she wanted to be on that toilet. She would sit there for an hour at a time. It increased the burden of care on the CNAs. It led her to have so many more issues, such as hemorrhoids. She had thrombosed hemorrhoids, bleeding, her rectum prolapsed, and she had to have a major surgery. So we really needed to go in there, look at her seating system, try to sit her in a position that could then allow that food to travel properly through her digestive system. The next issue that can arise with poor positioning is swallowing difficulties. And this is something that I think we are very aware of. We know that our head and our neck can very much so be affected with poor positioning. And when we allow our residents to sit with this excessive motion, they sit at end range. And so they're completely in forward flexion or completely in extension, and it really affects the swallow. You start to see the neck muscles tighten, and oftentimes they become contracted. So the negative result of that is you start having someone that cannot swallow correctly. You increase the risk of choking, you increase the risk of aspiration, and also the person is just embarrassed because they don't like to be around someone when they're drooling, food's falling out, they're coughing and choking constantly with meals. So this is a great time to step in, get a speech therapy consult to come in, work with them, co-treat, and say, hey, I'm going to start messing with the back support to try to position her better, to get her more upright and stabilize her. I'm going to mess with the cushion to get the pelvis stabilized. I'm going to mess with the seat to back angle. You tell me when she looks good and when her swallow is safe, and I will set her system up to that point. I'll get a head support. I'll do whatever I need to do, a lateral to keep her upright so that her swallow is safe. Okay, this is a medical concern that we don't think about enough, and that is the decreased communication. So what is going on? Just as with the swallow, our neck muscles start to tighten and shorten, and we start to have contractures form. And what happens here is the person is unable to bring their head up against the midline, against gravity, or maintain the midline. So the eye gaze starts going from midline downward or upward or to the left or to the right, depending on what their postural abnormality is. And it really starts to affect that nonverbal piece of communication. It's lost. And listening and hearing to what somebody says is just a small piece of communication. We understand what's being said to us and interact through that nonverbal piece, through the body language, through the gestures. You've seen me move my hands. You've seen my facial expressions change. You understand what I'm saying by looking at the whole picture. And when we don't take this into account, I compare this to living in a text messaging world. These residents are living in a text message world. How many times have you texted a friend and said, hey, do you want to go out to dinner tonight? And you just get the response back that says, no, I can't. And you're like, oh, gosh, is she mad at me? Did I do something? That was such a short response. Like, I think she might be mad at me. And the communication is broken down. Why? Because you can't hear that person. You can't see her facial expression. You can't see her body language. So you don't know, maybe she was at work and didn't want to forget to answer you and just wrote as quickly as she could, no, I can't. Or maybe she was driving and her daughter wrote, no, I can't, for her. You don't know what the reasons were, but you're going to jump to conclusions. Whereas if you could see her and you could see her face and you said to her, hey, you want to go out to dinner tonight? And she says, no, I can't. You see that she's upset that she can't. You see her body language telling you she's upset. You hear her voice and you understand. And this is how someone feels when they can never look up and see the environment around them. As well, when someone sits in this, their communication is affected because they have poor voice quality and projection. They're not sitting up. They can't project their voice quality is very low. And this lady is a perfect example of that. She had such fatigue in her muscles and she was so weakened that you literally had to put your ear like this close to her mouth to hear the faintest of whisper coming out from her. The next issue that can happen is a bladder issue. And yes, this woman is not, quote unquote, in a wheelchair. She's in a Broda chair, but she is still sitting in an abnormal posture. She is still sitting with a very severe posterior pelvic tilt, a kyphotic spine that is constricting her abdomen and her chest. And in this case, it is definitely affecting her whole entire urinary system. She has inadequate emptying of her bladder. She has more urge incontinence because her bladder is never empty and she feels like she's constantly having to go. She deals with chronic urinary tract infections. And they lead to even more issues such as significant bladder and kidney infections. This woman has been hospitalized multiple times due to sepsis, high fevers, change in mental status, all due to the fact that her urinary system is constricted. Okay, this is something I know we know a lot about, and our facilities want us to understand well. And so that dreaded wound risk is definitely a serious concern with poor wheelchair positioning. So I made a little recipe card for you, and you add in the ingredients that you allow this person to sit in an abnormal posture for long periods of time. Add in the fact that you're dealing with people that are end stage of life. They have natural progression of the skin changes. As we age, our skin thins, the statistic is 6.4% with every decade. So when you're dealing with a 70, 80, 90-year-old resident, you're sitting on paper-thin skin. You add in the fact that they have decrease in sensation. They just can't even feel peak pressures like you and I. It might take us 10 minutes to get off of that. It might take them 35, 40 minutes. Then you add in the fact that they have decreased mobility. They don't have the strength and endurance to bring themselves out of that abnormal posture. You put all that in a bowl and mix it up, you're definitely going to yield a wound at those bony prominences. And then lastly, something that we do not consider enough with poor wheelchair positioning, how it can lead to isolation and depression. How many times has your activities director come to you and said, hey, Mrs. Smith won't come to bingo anymore. She's not eating in the dining hall anymore, and rightly so. She's in pain. When I'm in pain, I don't want people around me. I don't want people touching me. They can't see what's going on in their environment. They can't communicate with the people through that nonverbal communication we talked about, or they can't be heard, or they can't see who's talking to them. When they're eating, they're drooling, they're choking, food's falling out, they're embarrassed. And also they have those incontinence issues. They think people think they smell, or they just feel uncomfortable being soiled for long periods of time. And we don't realize that this can lead to isolation and oftentimes depression. So we know that depression is a very serious thing in our nursing home setting. Let's see if the system that we have put them in is part of the cause. So what is your job as a therapist? Our job is to make sure that through the wheelchair model that we choose, through the equipment, the cushion, the back support, and any needed accessories, we can bring that person into maximum optimal pelvic and trunk alignment to limit the negative effects of that abnormal posture, to make sure that those medical complications that we just talked about are 0 to none. So during your evaluation, I'm going to talk about some very important key questions that you can ask yourself. And by answering these questions, you will gain some insight and learn some very pertinent information that you can take away and then translate to the seated posture that will help guide you to choose the appropriate equipment for each and every resident, because we're all different and we need to start thinking them as individuals instead of mass buying, bulk buying, and thinking that everyone will fit in the same cushion, the same wheelchair, and the same back support. So the first question is, what is the current seating system? So when you ask yourself this question, you should be thinking of some things. Have they been on caseload before with positioning issues? Are they one of those, what I call repeat offenders that keep coming back month after month after month? Or is this something completely new to them? And what have I used in the past? Was it just a general use cushion? That's all they needed, but now they're starting to slide, they're starting to develop a wound, and I need to step it up to a different category of equipment? And did it work? Maybe the issue is that you put them on the wrong style of cushion. Maybe the issue is that you forgot something and you only thought about a cushion. You didn't think about a back support or the correct model of wheelchair. And this is very common, and we all are guilty because this is how we've been trained for years and years and years. I think you all can think of a case that you have a referral come across your desk for seating positioning. You go in, and the first thing you think of is, well, let's see, what cushion are they on, and what cushion should I change them to? But what we need to realize is that it's so much more than just a cushion that will get us to an optimal seating system to prevent those falls and prevent those wounds. Okay, so what insight do we gain by asking that question? What is the current seating system? The first insight is that we have to stop, as I said, bulk supplying. We have to look at these people as individuals. And maybe you and I both are 5'7" and weigh 145 pounds. However, I have a very long torso with short legs, and you have a very short torso with long legs. So you need a very tall seat to floor height and a very short back. I need a very tall back with a very short seat to floor height. We need to stop fitting each other into the same size, 16 by 16, 17 inches off the ground chair, because what works for you is going to cause me to slide. What works for me is going to cause you to slump over. We have to stop putting everybody in the same equipment thinking it's going to work. The second thing that it's going to teach you, and insight will be gained, is what category of cushion and back support does my resident fall into. Most manufacturers, you just ask and they will give it to you, have algorithms, have decision trees, have comparison charts that really give you criteria of who is good for that standard general use cushion, who is appropriate for that skin protection, who is appropriate for that skin protection and positioning. And I know that there is a long-term care seating positioning guide that Direct Supply and myself can get to you that help guide you and give you this criteria to help you decide what category of cushion is correct. Another insight gained by asking this question is the back support. It is not just a cushion that is going to get you to an optimal seating system. A back support is just as critical. When your resident presents with one of these abnormal curvatures of the spine, that sling back that comes on the chair is not going to cut it. You need to start replacing those back supports with more specialized back supports that can immerse the spine, that can contour around what is their now normal curvature to really make as much contact with the spine to stabilize it, to keep it from moving, and to have even pressure distribution so that you don't get wounds along the spine. As well, it helps you to remember that maybe I need to add accessories. I truly am someone who thinks that less is more, but sometimes we can't avoid it. We need to add that lateral to give that last little push to help keep them in their optimal midline. We might have to add that head support to keep that head so that they have a safe swallow, that they can keep their head in midline to communicate. So it's always going to let us know what is their current system, what is it lacking, and maybe what should I add. And remember, it's not just a cushion. It's not cushion plus cushion plus cushion equals an optimal seating system. It's understanding the wheelchair models that are out there, combined with the cushion, combined with the back support, and then any needed accessories is how you get to an optimal seating system. The second question that is super important, because everything in our lives have to be function-based now, is what activities must the resident be able to perform? So when you ask yourself this question, you have to think, how much trunk stability do I need to provide for this person in order for them to perform their ADLs? Do they self-propel? Do they use their arms to do that? Do they use their legs to do that? Or do they do both? And then how do they transfer? Are they independent? Is it a stand pivot? Is it a stand-up lift? Is it a total lift? You need to know how these people transfer and what activities they need to perform. So what insight does that give you? And the first piece is the importance, again, of changing out the back support and realizing that all of us cannot have the same height back support. So there are two, when you're measuring someone and you're taking the measurement to really fit the wheelchair to the person, there are two measurements when it comes to back support. And if you look at our little lady, you're going to be focusing on letter G and letter H. So a higher back support should be given to someone who really has like a mod, max, dependent to sit unsupported. They really need a lot of stabilization because they can't do it themselves. So you need that back support to be higher to make as much contact with their entire trunk to really stabilize them to prevent them from moving or sliding. So you would take the measurement, get them out of their wheelchair, put them on a mat table on a firm, flat surface, and measure from the mat table all the way to the top of their shoulder in measurement G. That way you're making as much contact and stabilizing them as much as you can. The second type of back support that you might need to consider is H. Maybe this person has got more trunk stability, more trunk strength, and they need to be able to move their arms because they're very independent. They reach down to the floor to tie their shoes and put on their socks or reach up into their closets, and they need that freedom of movement at their arms. So you need to measure from the mat table up to the inferior border of their scapula so that you are not inhibiting their movement in any way, shape, or form. So you would measure more H. And again, this is in a seating positioning guide that we can provide for you that really helps you hone in on these measurements. The next thing it helps you to consider is what is the seat to floor height? Do they propel with their leg? And you need to make sure that you're supplying a wheelchair that can get them close enough to the ground so they can get a good heel strike to propel themselves without compromising the position of their pelvis, having them slide forward so that they can get their foot to reach the ground. The other consideration, it teaches you and reminds you about armrest height. Maybe you need a chair that has armrest height adjustability as well, because again, the most standard, the arms have to be jacked up in order to put your arms. You can't reach over to self-propel. It's hard to reach over the side to perform ADLs. It's hard to reach up and over them to get to your closets. So you might really be limiting to someone if you're not considering the fact that they need to use their arms to perform and function at maximum independence. Other things that asking this question might tell you is cushion style. Does your resident, how do they transfer? If they're more of an independent transfer, you might want to consider more of a linear cushion. This is a flatter cushion. And these are great because it makes it easy for you to get up and down from that cushion on and off. However, a pre-contoured cushion, which is actually designed, it has these hills and valleys and mountains, as I like to call them, built into the cushion, which by nature add borders and delineate where the pelvis is supposed to go, help to align the lower extremities to prevent movement. They by nature will make it more difficult to get on and off this cushion. I'm not telling you not to use this cushion with an independent transfer, but make sure that you haven't taken away their independence and they can still get on and off this type of cushion. Also consider what cushions can be used with slide boards. If you're a slide board transfer, make sure using that slide board is not going to puncture it, rip it, ruin it in any way, shape, or form, and take away the stability of the cushion and their independence. So the third question that you want to ask yourself is why? Why do they sit in this abnormal posture? And this is a very important question. And when you ask yourself this question, think, are they sitting in this abnormal posture of posterior pelvic tilt or obliquity or whatever it is that they're presenting to you with because they're trying to relieve pain? Are they leaning over to one side because they have pain on that one IT and so they're trying to get off of it? Or are they leaning over on that one side and into an obliquity because that's where they feel stable? They're in a wheelchair that's too wide. They don't have the trunk stability to make themselves stable, so they seek out the armrest on one side to feel stable. Or are they sitting in that position because they're stuck in that position due to a range of motion limitation, a contracture of some sort? When you figure out those things, you gain some insight, and it helps to give you hints as to what properties to focus on when choosing a cushion. So let's say you've realized that this person is sitting that way because they're trying to alleviate pain off of a painful area. So when you're looking at all those cushion choices and all the catalogs that you go through, look for words such as immersion or offloading. These are two principles that take pressure off of a small surface area, and put it over a larger surface area, which will by nature decrease pain. So again, if you've come to the conclusion that they are sitting in that obliquity or that posterior pelvic tilt trying to alleviate pain, really look for a cushion that boasts about immersion or offloading. If you come to the conclusion that the reason they're sitting in this posture is because they don't have the stability and they're seeking out stability, maybe the back support is too short and they don't have the trunk stability, and so they slide down into a posterior pelvic tilt to have more of their back making contact with the back support. They're seeking out stability. So if that's the case, then you should look into cushions that actually have those pre-contours, those hills and those valleys that we talked about that help stabilize the pelvis, help align the lower extremity through their borders and delineate where they're supposed to go, and help to prevent any unwanted movement. Or maybe it's in both. Maybe they have pain and a postural issue, the stability issue. Then look for keywords such as skin protection plus positioning cushion. This has the immersion and offloading property, plus gives you some contours to it to really help stabilize the pelvis all in one. If you come to the conclusion the reasons that they're sitting in this postural abnormality is due to a range of motional limitation, they have some type of contracture, whether it be flexion contracture or extension contracture, then a key word you should be looking for when you're reading the description of the cushions is adjustability. You want a cushion that you can take cells out, put cells in, take a piece of foam away, put a piece of foam in, somehow build up or break down the cushion to accommodate for the lack of range of motion at any given joint. So if you look at this picture of this gentleman, you can see that he has a very significant flexion contracture on that left lower extremity. And so before we went in there, he was on a cushion, and he had this much room between his femur that was kind of hanging out in the air and the cushion. There was no contact being made. So all of the pressure went straight back onto his IT. So what we did was we found a cushion with adjustability. I could build up and add cells under that to build up so that now the cushion was making contact with his femur, and he had even pressure distribution because the pressure was going through his leg as well as through the sacrum, so that all the pressure wasn't directly right there on that bony prominence of the IT. Okay, next question. What are the pelvis, the trunk, and the head doing when a resident is sitting unsupported? So things that you need to think about when you talk about this is when you put them on the mat table and you take away the stability, you walk away and see what their body does. Do they slide into an abnormal posture? Do they slump over? Do they start to lean to one side? If they lose their stability, what postural abnormality do they slide into? And does opening seat to back angle when you put them back into their chair, so that's kind of giving them a recline, does that help with the stability? Do they have less of a tendency to slide when you open the seat to back angle to make up for the range of motion that they lack? And that is really important because most of our chairs have a fixed 90-degree angle. However, most of our elderly residents, for all the reasons we talked about on the first slide, cannot sustain 90 degrees. So they will slide out of it. But if you open the seat to back angle, you are now matching the angle of the chair to the angle that their range of motion at their hip is. So maybe they have 105 degrees at their hips. Then when you put the chair at 105 degrees, they won't slide because you've now adjusted it to what their body can tolerate. And then think, all right, after changing the cushion, after opening the seat to back angle, after putting a back support that stabilizes them better on the cushion, am I perfect now? Do I have my optimal, or am I still lacking something? Do I need to add maybe an accessory to take it one step further and to get them to perfect? So insight gained by asking this question is it acts as a reminder. It acts as a reminder to help us to really consider the importance of angles in a seating system. You and I cannot sit at 90 degrees all day long. Why should we try to force them? So we need to use chairs that can open seat to back angle through the back canes, or by taking off the sling back and putting on a back support that you can adjust seat to back angle, like the one in this picture, and you can recline it and bring it forward. And you do that through the hardware. So you need to understand and remember the importance of angles and opening seat to back angle to match what their hips can do. And you also need to start thinking about the adjustability that you gain by changing out that back support. And so we're going to talk a little bit more about that. How does adjustability in the back support provide you more stability and more even pressure distribution? So if you put somebody in a non-adjustable back seat, so that sling back that comes on, or that tall recline back that's just straight and taut, when the person sits against it, it's only going to make contact with the back support at the apex of their curvature. So if you have a very kyphotic spine, it's only going to make contact right there at the apex of that kyphosis. So you're going to have pressure entering that back support like daggers into a small diameter. When you can put them in a back support that you can adjust and contour to the person's curvature, and you're accommodating their curvature, you're not going to be able to change most of these curvatures, but you need to accommodate for it. You need to capture what is now their normal. You need to make sure that you're wrapping around them, enveloping them, and immersing them so that you're not making contact only at the apex, but that you're making contact along the entire spine. And when you can touch the entire spine, you're going to be able to stabilize it much better. You're not teetering off of one point. You're touching the entire spine to stabilize them to prevent that movement. As well, you have pressure coming in evenly, like you can see in that picture, along the entire spine, and you're going to decrease the risk of a wound happening along that spinous process. So when you have more surface area making contact, you will be able to increase their stability and decrease their risk of a wound much better when you replace that swing back or that taut straight back with an adjustable contour back support. Another insight gained is the fact that sometimes you need to take it a step further. You can see in the beginning picture, this resident, this case study started off pretty rough. We changed in the middle picture, we changed her back support, we changed her cushion, and she started looking pretty good, but still not great. So we had to take it one step further, and we realized we needed to add the accessory. We needed to add that lateral to help keep her up when fatigue and gravity really started taking effect, especially at the end of the day. We needed to add that head support to keep her head up in alignment so that she could see her visual field, so she could swallow safer, so she could project her voice better. So sometimes it just helps us to point that we do need to add some laterals, some accessories that are going to help get to that optimal midline. All right, and the last question to ask yourself is, can the resident move in and out of that abnormal posture, or is that posture fixed? So if the posture, when you palpate the person's pelvis and you see that they're in a posterior pelvic tilt, but you can bring their pelvis back to midline, you can actually move their pelvis. This is termed flexible. Another term is reducible. So you can actually reduce the amount of postural abnormality that the person has, and you can bring them back to midline. However, if you touch the person and you try to bring them out of that posterior pelvic tilt and you cannot bring them back to midline, that is called fixed. Or now we're changing our terminology to be called non-reducible, meaning that you're not going to make it better. The only direction it can go is to progress to be worse, but you're never going to make it better. So we need to learn to change our mindset and change our goals, whether the posture is flexible or if it is fixed. So the insight gained by asking this question is just what I said. It's going to define your goal for your cushion and your back support. If the posture is fixed and you cannot bring it back to midline, or it causes them way too much pain to try, then you're going to accommodate for that abnormal posture. You're going to start to think of words like, I need to envelop them, I need to immerse them, I need to accommodate for what is their now normal to make sure it doesn't get any worse so that I don't create a wound and decrease the pain. If it is flexible, you can bring it back to midline, then your goal is not going to be accommodate. Your goal is going to be to correct it. You want to use equipment, and the way you use your equipment is to try to correct it. So here is a great example. We're dealing with someone with a pelvic obliquity in this picture. If I have palpated them and I see that their obliquity is flexible, so I can bring them back to the neutral, back to midline, and I can create that not to have one of the ITs jutting into the cushion. I can bring it back to that even neutral. Then what I want to do is, with my equipment choices, is I want to build up under the lower side to bring that pelvis back to equal. However, if when I touch my person and I realize I cannot bring it back to even, there's no way I'm getting that pelvis back, it's stuck like that, it's fixed, then I'm not going to try to build up the lower side. That's just going to cause them pain and excruciating pain. What I need to do is fill in the higher side. So now that side that's barely making any contact, I'm going to build up underneath of the higher side. So now it's making good contact with the seat surface, and there's even pressure touching that IT as it is with the lower IT. And you now have a more even pressure distribution, and all of the weight is not going on just that lower IT. Okay. So lastly, the goals. What are your goals when choosing equipment? Our number one goal should be we want to maximize that trunk and pelvic stability to prevent that unwanted movement and to maximize pressure distribution. And we do that by using those algorithms. We do that by using those decision trees, looking at that criteria and finding the correct cushion and back support that have properties for wound, to help with wound healing, to help prevent wounds, that have skin protection properties. We also have to utilize the appropriate model of wheelchair. Think about it as an equation. It's a chair plus a cushion plus a back support. We need to look at all three and see how they can be changed and configured to accommodate or to fix whatever that resident's abnormality is in their range of motion limitations. The next thing we need to do with goals is we need to take it a step further sometimes and recognize that it's okay, and sometimes we need to add those accessories. We need to add that lateral support. We need to add that head support that's going to help maintain that midline, to help maintain their optimal posture to prevent any more sliding into unwanted abnormal postures. And lastly, definitely we want to maximize comfort in their seating system for the longest period of time. So keep in mind, and I've said it many times throughout this course, and I mean it, seating systems, it comes down to a simple equation. We have to use those algorithms, get to the appropriate style cushion. We need to couple that with the back support. Stop using those sling backs, get rid of those taut straight backs, and start using back supports that can immerse someone, that can accommodate for the curvature that they have to help stabilize the spine, that will then in turn stabilize the pelvis. And we couple that with the appropriate wheelchair model. Take the measurements and realize that you and I will never fit into the same size chair. And then you will get to the optimal seating system that you will then in turn be able to have maximum contact with your seat and back surface to achieve that postural stability, to prevent that leaning, to prevent that sliding, to prevent that slumping forward. Then you will be able to have that even pressure distribution to make sure that you don't have peak pressures at those bony prominences, and will prevent wounds and help to heal existing ones. And then you will be able to attain and maintain that postural alignment so that you can have them maximally function at their highest level of independence. And so I thank you for this course. Here are some of the references that we used. And the last thing that I will tell you is that, as I've mentioned a couple times, Direct Supply and I both would love to offer to you. We have some very great resources out there, such as the product selection guide that has those algorithms, has those decision trees to help guide you to the correct product category. And then we also have the seating positioning guide that helps give you these principles that we talked about today to act as a reminder while you're doing your easiest to hardest positioning case. So thank you.
Thank you, Ana. That was really great information. We do have time for a few questions. So if you have any, please feel free to use the chat feature or the Q&A feature in WebEx and send them over. We have one that came through, and it is, what are some national resources that I can utilize for additional pressure management and positioning education?
I'm sorry, can you repeat the question again?
Sure. What are some national resources that I can utilize for additional pressure management and positioning education?
Did you say national resources?
Yeah. Yeah.
Okay. I'm not exactly sure what's meant by that question, but some excellent literature that is out there. If you go onto Resna's website, they have fantastic things called position papers that really talk about pressure management and how to use pressure mapping systems. And then, of course, the NP-UAP puts out fantastic materials on the stages and how to prevent it, and really talk about principles of pressure redistribution. Because we will never be able to completely eliminate pressure, What we can do with our equipment choices is redistribute the pressure. Take it directly off of those bony prominences and make it go through a greater surface area. I hope that answers the question. I wasn't exactly sure what was meant with the question, so if someone wants to clarify that, I could take it a step further, or if that answers it.
I think that's perfect. Our next question is, if someone is windswept on the right side and recently had a hip replacement, what ideas would you have for positioning? She can fix it with verbal cues, however, after a minute goes back into the windswept position.
Yeah. So that's great. If she can fix it with just verbal cues, then that means that she is not fixed. She is flexible and she can get back to optimal. So with someone like that, I would highly suggest looking for a positioning cushion, more of a pre-contoured cushion. They have, and this actually comes in another course, so I encourage everyone to take this course when it shows up. It actually has something called adductors on the side that kind of act as borders. That in combination with a pelvic well and a medial abductor, it really helps to align the person's legs. So for someone who can't remember or doesn't have the strength to maintain their legs in alignment, those pre-contoured cushions will do that for them. So you probably want to stay away from more of a flat cushion, a more linear cushion, and start looking for cushions that have built-in contour that will give them the shape and help maintain that position for longer periods of time.
Excellent. Thank you. All right. I have one more question that just came in here. One second. What can nursing homes with limited resources do to combat inappropriate positioning? Don't have a lot of money to buy cushions.
Yeah, that is a very, very difficult question because I struggled with it myself. And, you know, this is how I did it. And it took me a long time to build up the confidence between me and my administrator and my nursing staff to know that I wouldn't just go out and just purchase anything, that I put a lot of thought and consideration into everything I purchased. And my suggestion to you is, number one, get in contact with a manufacturer. Ask them if they can trial something. Get in contact with Direct Supply. See if they might be able to do some type of trial program. Some of the equipment can be returned. But take it one case at a time. I know it's not going to happen to go in and say, I need a whole new fleet of wheelchairs. I need all new K4 wheelchairs. All those K1s with the fixed 90-degree angle don't work. That's not going to happen. But if you can take it one person at a time and really change that person's back support out and their cushion and see the difference and show them the before picture and the after picture, then little by little, they're going to know that the changes you make a difference. I also encourage you to really talk to your administrator and to your nurses. Ask them to take courses like this because at the end of the day, things are changing. There's legislation coming. The prospective payment system, it's all outcome measures now. And if we don't get these outcome measures the way they need, it could affect your facility's ability to be reimbursed. So like I said, take it one patient at a time. You're not going to go in and make waves and huge change all at once, but if you can just show them one hard patient at a time how you've corrected it with the appropriate choices, and yes, it's more expensive up front, but in the long run, you're not getting the wound. You're healing the wound that they had. They haven't fallen 6 months from their chair. That will speak volumes to your administrator and to your nursing staff.
Thanks, Anna. Another question is, if an individual is dealing with chronic lumbar spine pain and leaning to the right as a result, what recommendations do you have to keep them at midline?
With that person, I definitely would recommend looking into a new back support. I would definitely look into a back support that can contour to the person's back. I don't know what they're in right now, but I would probably say they're just in the typical swing back or the straight back, even if it's a reclined back that you have. And when someone has that much chronic pain, the more that you can contour around their spine, the more that you're making contact, relieving pressure, relieving pain, and they're going to thank you for it. So I would highly, highly suggest the first step is looking into a very good back support that can contour to the spine that they have.
She just commented and said that she has a contoured backrest already. Is there another step?
The contoured back that she has, is it a contoured back that she can adjust, or is it a contoured back that's not adjustable?
Stay tuned. We'll see if she responds. I do have another question here. Let me open. Let me open this up. Sorry. She says she has to adjust it.
She has to adjust it. I would probably say the next step is to make sure you play with seat to back angle in the wheelchair system, because what it could be is that she's just too upright and all that pressure continues to go straight up her spine, and even though you're contouring, you're not opening it up enough. So I would play with seat to back angle a lot with her. Make sure that you have, I hate to say this, but I don't know what back support she's in, but some are fantastic, some are medium, middle of the road. And it could just be as well that seat to back angle isn't appropriate for her, and then that in combination with the cushion could be the issue if you feel like the back support is already good to go. And one thing that, with this case, talking to her, and I can't see the patient, I can't see any of the equipment, but seating position truly is a lot of trial and error. Making one little change, seeing how it affects them, then changing another thing, seeing how it affects them, and sometimes it takes a good 20 changes before you find what works for the person. So it sounds like you're on the right track, though, with the contour that you're getting out of the back support.
All right. Thank you so much. Okay, we are out of time for questions. If you do have additional questions, feel free to email webinars@direxsupply.com and we can send your questions over to Ana and get them back to you. As a reminder, by attending this month's webinar, you will receive 1 nursing contact hour, 1 physical therapy contact hour, 1 occupational therapy contact hour, or 1 complimentary administrator CEU. To receive your final certificate and contact hour, you must fill out the follow-up survey, which I'll put in the chat area shortly, and it'll be also emailed to you tomorrow. Please note, if you're watching as a group, you must each fill out the survey to receive your certificate. You'll have 1 week to complete the survey, and then you'll receive your certificate within 2 weeks. And now, for anyone who's interested in learning about the cushions and other seating products that Direct Supply offers, please help me welcome our awesome Senior Product Consultant, Kelly Sullivan.
Hi everyone, thanks for sticking around for a few minutes. We're going to discuss a few products here that will complete your seating solution. So when we talk about a system, as Ana mentioned during the presentation, it truly is just that. One thing isn't going to answer to all of the needs of the individual that you're trying to solve the seating positioning needs for. It really takes an and product. And so we're going to talk about a few different options that we have in our portfolio. The first one I have here is called the Shield. It is a product from Comfort Company. It truly is a wonderful product in that it allows for deep immersion into the seated surface. It has many features that actually allow for them to categorize this as up to stage 4 wound. So it's a foam cushion rated through stage 4. That's pretty unique in itself. When we look at the cover here, you'll see in the back towards the pelvic region, there's this different material. It's called glideware. And it helps to mitigate shear with those micro movements while the resident is seated. So if that person is moving or shifting a little bit in their seat, that shearing is going to be mitigated with that particular fabric that's built into the cover. As we open up the cushion here, I'm just going to take a peek inside for you. You'll see that there's a second cover here. And this is an incontinent-proof cover, so you won't have the worry of any kind of fluid penetrating through the first cover, since you have a double cover here. That's going to allow for that protection from the foam. Let's open up the inside here. This is a 3-layer foam cushion. The top layer is visco memory foam, so there's good immersion here. It helps to offload pressure. You'll see here there's a coccyx cutout to help alleviate pain or lower back pain. You'll also see that the pelvic region's carved out to help offload pressure from the IT area. And if you look to the front here, it's contoured, kind of like a saddle. So it helps with abduction and adductor control. It truly is a unique product. Definitely, I would say all people could benefit from it. I actually sit on this at my desk, to be honest with you. It really is a beneficial product for any individual that is, whether they're at risk or even if you're looking at a preventative measure. All right, we're gonna move on to some air cushions. The next cushion I'm showing you here is called the Vicare Vector. This is their original line of product, the Vicare Vector. They have many different options under the Vicare brand. This one here, the Vector, has multiple different compartments, as you see here. What makes this product unique is that you can take it right out of the box, put it on a wheelchair, and it's ready to go. When we talk about stage 4 wounds, once again, or stage 3 wounds even, you know, having an air cushion that, you know, requires a lot of maintenance can be cumbersome. There could be some worry attached to that in terms of the air levels are going to be checked on a regular basis. This cushion helps to, I guess, alleviate some of that worry because you don't have much maintenance with this cushion. So if we open this up, I'm just going to set this down here. There's different compartments, and you'll see falling out here are little air packets. They almost look like sour cream packets, if you will. And they can be added or taken out of each and every compartment that you see on the surface here. So what we're doing is we're allowing for positioning, answering to those positioning needs. So if I want to build up a pommel, I can do so, or maybe I want to create a coccyx cutout. With some of the models, you can do that. Maybe there's some lateral leaning that you're noticing as you're looking at the biomechanics of the resident, where you can look at maybe building up one half of the cushion to help center them or encourage them to a more central location on the seat. So there's lots of ways to, you know, solve for positioning, but also there's a pressure management solution for you here in this cushion. I'm going to also pull out an example of their X series. So this is also the Vicare line, but it's a different set of cushions called the X series. So they've made some changes to the surface. What they did here is most you can actually order with that glideware with this particular cover. So it, again, helps to mitigate that micro movement and shear force. As we open up the cushion here, I'm just going to pull this out, you'll notice that the cushion itself has mesh fabric on it, so it's very breathable. You can throw this in the washing machine. So then again, when we talk about maintenance, it's very easy to manage. This one here actually is kind of a hybrid. It has a foam and then the air pieces along the pelvic region here, where you can take the air packets in and out to create some changes to the surface for positioning needs. But there are, again, many different options for you to choose from. The Vector has actually 10 compartments. The adjuster has, I believe, 5 compartments. So there's lots of options for you to kind of change the surfaces and assess based on the individual's need. And the good news is that we have some decision trees available for you that we're going to send out in the follow-up email that will help provide some guidance as to what cushion's best for the indication at hand. I also wanted to point out, you know, one of the things that people worry about with air cushions is that, you know, movement and kind of shifting on that surface. So here they actually have an insert built into the cushion base, so it helps to create a little bit more stability for the individual as they're seated on the surface. All right, and then we're going to move over to a back. So again, it's not just a cushion, it's a seated system. So we're talking a back, a cushion, possibly lateral supports, depending on the individual. So this particular back is called the Active Relief. It is a true rehab back. So it's going to have a lot of adjustability. Ana mentioned during her presentation that, you know, with someone who's kyphotic or has spinal curvature, that you really need to accommodate that spine and the movement or the contours of that spine because of those pressure points that would drive down from a rigid type back. This is going to actually solve for that. If you have someone that you are working with that has is kyphotic or has a spinal curvature, this you can see as I push into the back, it's going to allow for me to immerse into it. So it's going to accommodate that spinal curvature. And as they move into that back, what I can do is, these are called BOA reels. I can tighten these reels and I can lock this in that position in place. So that person is going to be, it's almost a customizable back, I guess I should say, where it's going to accommodate that individual. The foam in the front here is visco memory, so it's very comfortable as they're seated. It's attached via hardware here, and you do have laterals alongside here that are moldable. So very, very good back if you have an individual that you're trying to solve for that has some spinal curvature and you're looking for a max assist type approach. All right, and then lastly I have here a quick and easy lateral support system. This is a Panacea product. What you can do with this particular product, well, first off, it just takes literally a minute to throw it on a wheelchair. It's a Velcro wrap, so it just wraps around the wheelchair, or it can wrap around a recliner as well. The laterals here, it's minimal support, so I do want to preface that, but it does help with some guidance, and it has some customizable options here for you to tap into, because these are Velcroed right onto the surface here. So I can move it up, I can move it down, so left to right or up and down. You have some flexibility in terms of how you're supporting that individual's trunk. And, like I said, it's going to allow for multiple different widths. So you're going to have, I think it's 16 inches out to 22 inches in width. So multiple different types of wheelchairs and or a recliner if you have an individual in a recliner. All right, and that's all I have today. I appreciate you sticking around and learning about products. We'll send out some information following this WebEx on those products as well as those guides that we mentioned. And I look forward to seeing you all again soon.
Thank you so much, Kelly, and thank you to Anna for that informative presentation. If you have any questions about the products discussed, please reach out to your Direct Supply account manager. For more information about upcoming webinars or to view past webinar videos, please visit directsupply.com/webinars. Once again, thank you for attending today.